Hello and welcome to the Dental Medical Emergencies podcast series, brought to you by the Dental Medical Emergencies team at the University of Leeds. This series aims to deepen your clinical understanding of medical emergencies and the challenges surrounding their management. We hope you enjoy the podcast.
So welcome to the first episode in the Dental Medical Emergencies podcast series at the School of Dentistry here at the University of Leeds. I'm Tamora Shenwood, I lead the Medical Emergencies team here and I'll be your host for today's session. Today I'm joined by restorative dentist and clinical teaching fellow Jonathan Pearson and 5th year dental surgery student Alicia Hussain. And together we'll be exploring factors that may influence confidence and competence when managing a medical emergency. Jonathan, Alicia, thanks for joining me today. So I know you've both had recent real-life experience of dealing with medical emergencies, but that the circumstances of the emergencies were actually quite different for both of you. Jonathan, do you want to start by telling us a little bit about your recent experience?
I can, sir. Thank you for having me on the podcast. So I was working in one of the LTHT sites, one of the dental outreach centres. It was Friday morning and it was fairly early on a Friday. The first set of patients were coming into the clinic. We had a patient who attended for a root canal treatment, and this particular patient was quite keen on having the root canal treatment done. However, they'd been quite unwell recently. They'd had a chest infection and they'd had some antibiotics from their doctor and a course of steroids that they were coming to the end of. The patient made us aware of this, and we decided, because the patient wasn't feeling too great on the day, that we were going to delay their root canal treatment, and we decided just to do a brief assessment, dental assessment of that patient, and then to discharge them. The patient attended with their partner. However, the partner had driven back home, so we contacted the partner to come and pick the patient up. After we'd completed the assessment, the patient was feeling a little bit better. They felt absolutely fine to leave the surgery, and the partner came, collected the patient. Approximately 20 minutes later, we were made aware that the patient had deteriorated. The patient was sat in the waiting room with her partner, and she was becoming quite breathless. So the receptionist made us aware that the patient was quite unwell, so they alerted both myself and the lead dental nurse. So when we got out into the waiting room, we noticed that the patient was quite breathless, and I asked the lead dental nurse to fetch the medical emergencies trolley. We started to begin our ABCDE assessments of the patient at that point, and we noticed quite quickly that the patient did have a wheeze. We put the pulse oximeter and we found that her oxygen saturation levels were at 86, which was quite alarming for us. And so we immediately asked the reception to phone an ambulance. We provided the patient with oxygen. We accessed the patient's medical notes and we realised that they were an asthmatic, and so we decided to also give salbutamol as well. So we gave a few rounds of salbutamol. We continued on with the oxygen whilst we're waiting for the ambulance to arrive. Thankfully, the patient's oxygen saturation levels improved quite dramatically when we gave the patient the oxygen. Soon after that, probably about 10 minutes later, the ambulance arrived, and then we were able to discharge the patient to the ambulance crew. They did their own assessment of the patient and decided that they were going to take her into hospital.
So sounds like a bit of a team effort, lots of equipment, lots of collaboration, lots of people to call on. Alicia, I'd like to bring you in here because it sounds like your situation was quite different to Jonathan's.
Yeah, so I'd say that it was quite different because I didn't have all the resources that Jonathan had in that sense. So I was going into town on a Saturday to do some shopping, and I was walking down, had my AirPods in, wasn't really concentrating, and suddenly two people just ran past me. It kind of alarmed me, and I looked over to where they'd ran, and a person basically collapsed to the floor. So my immediate response was, right, maybe I should go over and help. So I went over, and as I went over to see the person, they'd started fitting on the floor. So immediately I kind of started that A2E assessment in my head. But at the time, there was lots of people crowding him, and it was kind of that stage where I was like, do I say, oh, I know how to deal with this, or I can help? And they started to touch him and trying to hold him down whilst he was fitting. And at that point, I was thinking, nah, you're causing more damage than good at this point. So I just said, oh, I think I might be able to help. And so they said, yeah, go ahead. So with it being quite obviously a seizure, I let the fit go through. Obviously, I didn't have access to oxygen, which is what you'd usually give, or I couldn't. He was already lying flat. But I let the fit go through, and I asked his partner at that point if he'd had a seizure before, and she said that he hadn't. So I just asked, well, could you ring an ambulance, please? The fit went through, probably finished in just under 5 minutes, I'd say. And then I was like, right, I need to start this A2E assessment again and just check what's going on. At that point, a lot of people were like, oh, he's not breathing, we might need to do CPR. And I'm just thinking, oh, I really hope not. So went through the A2E assessment, and he was basically unconscious, but he was breathing. So I started to put him in recovery position. And he did start to vomit at that point. Yeah. So then tilted his head back and lifted his chin up. So it kind of stopped the airway from being compromised. And then I think this is probably where like the teaching came in the sense of he started snoring, and I remembered, oh, that must mean that his tongue's like flaccid and it's going back into his throat. So tilted his head back a little bit more. And then with him being in recovery and his head tilted back for quite a while, he then started to regain a bit of consciousness and became a bit more alert, wasn't speaking. And by that time, the ambulance came and they took over, and they were just saying that it was just good that we basically stopped his vomiting from going in and him choking, essentially. But yeah. So
it sounds like a really challenging situation that you've actually managed really well, because not only have you gone to a person in need and taken the lead, but you've also stopped, the layperson from harming whilst they're trying to help. So what was it in your teaching? You said that some of the teaching started to come back. Were there specific aspects of the teaching that you think gave you confidence to go in there and be that person in charge, even though you were stripped back of all your normal support systems?
Yeah, for sure. So I think, firstly, the fact that I'd completed my exam recently, and I'd known I'd passed as well, I remember going over thinking, because at first I was like, I don't think I'm qualified to do this when I walked over. And then I was like, well, no, theoretically you are, like, you've done the exam, and if you're not going to use it now, then what was the purpose of it? So I think just having done the exam and knowing I'd passed it meant that I thought, no, I should be able to do this. And if I don't do something, then it's bad, because I've been given the teaching to do this, so what am I supposed to use it for? But I also think the structure of the teaching, so having that A2E structure, because I think when you go in there, in that situation, everybody was panicking around me, and it's really hard to not panic as well. And I think just knowing you've got a set structure to follow, it brings you back down. You're like, right, okay, start with airway, go to breathing, go to circulation, like go through it. Whereas I think if I didn't have that structure, I probably would have panicked as well. So I think it's good to have that baseline.
Yeah, so just for a little bit of context for the reader, our undergraduate students receive medical emergencies theory, but then that is supported by clinical skills sessions, making sure that they're able to use all of the equipment, and also simulation practice in a high fidelity simulation suite. They then go on to sit a progressional assessment where they actually have to manage an unknown situation within the simulation suite. For our staff, it's a very similar process, but they come to us every other year for training updates, and there's no assessment associated. So I wonder if, from what you're saying, if the actual assessment played a role in your confidence to move out of your comfort zone into such an alien situation, because you'd almost had that stamp of approval.
Yeah, no, I agree, because I do remember walking over, and I think my instincts were, I don't know if I can do this. Like, am I going to cause more harm, or am I allowed to do this almost? And I think just knowing that I'd passed the assessment meant to me, well, I've had approval from the school, so it's not even that I'm allowed. I should be doing something here, because you've got the theory and you've essentially got the skills to do it, so you should implement it. And I think another thing that really played a part was the fact that no one else really knew what to do. So I thought, if I don't do something, then
someone's going to do something wrong.
Yeah, and it's going to cause harm. And I think it was when they were touching him and trying to hold him down, and then when also they were like, oh, he's not breathing, we need to start CPR and things. And I was like, no, let's wait, because it would have caused more damage than good, I think.
Yeah. If the patient's breathing, then their heart is definitely beating.
Yeah.
How did you present yourself to the other people that were there? Did you introduce what your role was? Or?
It was really funny. So I went over, and at first I kind of just stood there because I didn't know what to say. And then I was like, I'm a dental student. I think I can help. And then I think they all just were like, yeah, just help.
Please.
Yeah. But to be honest, I think actually one of them had misheard me, because they kept saying on the ambulance, oh, there's a dental nurse here. But yeah, I think I thought that was quite difficult, because at first when I first walked over, I was kind of lingering, stood there for a few seconds, because I didn't know, there was too many people, so I didn't know how to basically go in and say, oh, I can help and lead it in that sense. But yeah.
Very good. So, again, core differences and that permission to act. Jonathan, thinking of your experience, being in a dental hospital surrounded by your colleagues, and you were in a different place in the training pathway, so you'd only had the theory by this point, is that correct?
Yeah, that's right.
But so you had less practical experience, you weren't as far through the training pathway as Alicia was, but you were surrounded by your colleagues and in familiar settings where you know the policies, you know the processes. Did you feel any of that similar permission to act, that you needed that, or do you think the environment changes that?
Yeah, I think the environment does change that. So I think there was an expectation that I was going to lead it. The lead dental nurse obviously helped a great deal through the proceedings. However, I took it on myself as to lead the medical emergency. The setting that we were in it has a doctor's surgery, it has other healthcare professionals in there as well. However, the unit that we're in, we're sort of away from everything else, and we're a little bit more isolated. So I did feel the need to be involved. I didn't feel as though I could stand back and wait for somebody else to take the lead. I felt as though the DENTAIM, so the theory that I'd done, was really helpful. It allowed me to know exactly how to assess the patient and to work out at what point to start to administer the medicine to the patient as well. Because my previous medical emergency experience or training experience has been purely based in practice, where it's much less formalised, I would say, than what it is with the dental school. Because I joined the dental school just before the pandemic, which meant that I've not actually had any formalised training from the dental school at that point. And so that was quite useful in having that formalised theory that I could rely on. As I say, the previous experience that I've had from training is much around CPR and how to actually use the medicines rather than assessing the patient. There's definitely a lot less emphasis on that in the training that I've had previously.
So this is training delivered within a community dental practice?
So this is, just in a general dental practice where somebody will come in for a morning and deliver the training. So that formalised training pathway, or at least the start of it, because I've not yet done the practical aspects of it, were very helpful.
Yeah. And do you think, so it sounds like there was a difference between you in feeling of responsibility and ease of saying, "Hi, I'm here, I know what I'm doing." Do you think where you both are in your careers might have had a role to play in that? That maybe, Jonathan, I'm kind of suggesting that you're used to taking the lead, to making decisions, and Alicia, you're maybe used to, you're starting to make those decisions, but currently you've still got a tutor in the background. Do you think that played a role for the two of you?
I think so, definitely. I mean, Alicia will know about this, when you've got a sort of a dental student and dental tutor relationship, it's the same for clinical dentistry, is that there will always be a dental tutor there who will be able to bounce off, and if there's any issues or problems, they will be expected to take the lead. So it's kind of a role that I'm used to. I hesitate to say firefight, which sometimes it can be when you're isolated out in the outreach settings. So I think that experience and the fact that I've been qualified, it'll be 11 years now, I think naturally you gain more leadership skills. Even if you don't necessarily go on specific leadership courses, you do pick up these skills just as you progress through your career.
Yeah.
I was going to say I agree, because I have Jonathan for outreach, and if it had happened on a Friday when I was treating a patient, I think I would have just fallen back to Jonathan and be like, oh, what do I do, kind of. And I think Jonathan would have taken the lead, and I think it's just because he's obviously a qualified dentist, and although we've had experience on clinic, you kind of always have that safety net in the back of your mind that, the tutors know, they've got the experience, they know better. And I think I would have just probably let Jonathan take the lead on it if it did happen to me on a Friday on clinic.
Yeah, so the role of experience more broadly within your dental careers definitely plays a part here. But from my point of view, there are other factors here in that, Jonathan's only part way through, and you clearly, from what you've described, you know what to do. And, you can always support those staff. 2 weeks earlier, Jonathan wouldn't have even have done the Dente modules because you're new to the school. So in that situation, you would have actually been the person who had greater theoretical knowledge. And I think that's always something to consider, that when you're working in these more traditional hierarchies of student versus tutor, we need to be mindful not to assume that just because somebody is a clinical tutor that they're necessarily up to date on their CPD, whereas you know what you've done, you know what you know, and you've got a stamp of approval of a superb assessment performance to back that up. So I think that's interesting. Something else I'd like to explore with you both is the access to the guidance and the materials, and what the impact of, because we use the quick reference guides within the school and the LTHT sites to scaffold both our learning of the dental medical emergencies, but also for that in situ use. What did it feel like when that was taken away? And Jonathan, did you actually use the quick reference guides, or were you just drawing straight from your head?
So I was actually drawing straight from my head.
Right.
So I wasn't aware of the actual quick reference guide, that we had it available to us, and the table as well for putting for monitoring the patient and putting the details on there.
The observation chart.
The observation chart. Yeah, we didn't have. I was unaware that we had that available as well, and I think that might come from a place where you're expected to lead something, and you almost in yourself feel as though you're expected to know what to do as well.
Right.
And so you don't want to start opening books and allow the patient to see you opening books. So I think that may play a part as well. now I've done the practical side of it, and I've seen how important it is to have that quick reference guide out and to have that observation sheet, and how useful that is to be able to go through it, not just for the first assessment, but when you're repeating the assessment as well. It's something, if I was to have managed the medical emergency again, I would definitely have relied on that, because we were relying on, as a team, of remembering these observations in our own head.
Yeah.
And using a clock, and not necessarily noting down the times that we were doing it, and just getting sort of using our phones to time it rather than actually writing it down.
So we all hope that you're never in this situation again.
Absolutely.
But should you ever be, it sounds like the training, or the second part of the training, focusing on that kind of practical application and assessment, and knowledge of those resources, will actually change your practice. It's going to change how you lead next time.
Yeah, absolutely.
And Alicia, you've definitely had use the scribe sheet, use the scribe sheet, write everything down, drilled into you.
Yeah, definitely.
So what was it like when all of your scaffolding that we've drilled into you was whipped away?
I think this is where the two parts of like the training comes into play, because so like Jonathan was saying, actually the second half of like doing the practical, that's where you get to see the real value of using the reference guide and noting everything down. So in practice it's really good. But actually I think the DENT-AIM theory was probably what got me through my medical emergency, because it gave me the understanding, because I feel like the reference guide just tells you what to do, but the theory gives you why you do things, and I think that's what helped me remember. So things like when he started snoring, I knew that his tongue had gone back into, had gone flaccid, and then I'd put his head up, whereas I don't think the reference guide necessarily tells you that.
Yeah, your quick reference guide is very much focused on what to do, whereas the DENT-AIM modules is why you do what you do.
Yeah, and I think for me, the way I learn things is I have to understand it at least a little bit for me to remember it better. So I think if we hadn't been given the DENT-AIM and it was just memorise a quick reference guide, then I probably would have struggled, because I didn't obviously have the quick reference guide or anything to work with. But it was the DENT-AIM, I think, what came into play for my medical emergency anyway.
Yeah, that's. I think that's a really valuable reflection, because I think definitely in my experience of working with both staff and students, some people that come through the medical emergencies suite are so into the quick reference guides because they're quite easy to follow. You can use them in situ, and it really does scaffold the situation. But then we see that they've maybe neglected that deeper understanding that you get from the other learning elements like DENT-AIM, which means that they then struggle when they encounter an atypical patient, or the situation is slightly different. There's, comorbidities that means you can't act exactly as the algorithm suggests, and they can't kind of work backwards because they haven't got that underpinning theory. But it's very clear that you absolutely have, which is fabulous. So this is, going through a medical emergency in these different settings, we can definitely see that there are differences, there are, different challenges, etc. But I'd really like to know about how you felt as you were going through this, because human factors is one of the most powerful influences that we see in medical emergencies. We have people that really understand their stuff. They have secure clinical skills, but, emotion and cognition, they're so closely linked. If you become... you have a huge emotional response, then sometimes it turns our head to strawberry mousse. So I'd really like to know how you actually felt, and what helped ground you in this situation.
Yeah, I think when you realise that it's potentially a medical emergency that you're dealing with, all of that theory and knowledge just floods your mind completely. And I suppose it's a bit similar, and Alicia will have more experience recently of this, of almost like opening an exam paper and reading the first question, and everything that you've ever learned starts to flood out, and you start to get a bit jumbled in your head. So I think it's just taking a little bit of time just to slow down, to breathe, and then start to go through that A, B, C, D, E assessment. Because I think that's what helps you just to start to break things down rather than taking all of that information in one go. And the adrenaline starts to pump as well.
Yeah.
And your own heart rate starts to go up, and you can start to feel it, and your palms start to get a little bit sweaty as well. And I think there's an element as well of not wanting the patient to see that.
Yeah,
for sure.
And I think you can try and hide that as well. And then sometimes, I mean, I felt when I was managing that medical emergency, you maybe overcompensate for that as well, for that the sort of anxieties of dealing with it as well. And it may come out as, I don't know, maybe a bit of bravado and overconfidence in dealing with the situation as well. But I mean, we were in a situation where thankfully the patient was responding to the treatment that we were giving them. And when you start to see that improvement, then that's thankfully when your heart rate starts to go down, the adrenaline starts to pump a little bit less and makes it much more manageable.
Do you think, because like obviously you're a tutor and like you said, that expectation that you have to deal with it, do you think that makes you, do you think that impacted on making you more nervous or like...
Pressure
because you've
to
got
perform.
that pressure there.
I think so. Yeah, absolutely. And there was a treating student there as well, and a treating student who probably like yourself has just completed the assessment, who's watching on. And so I think that's why it was important to get them involved in the team working aspect of it as well. But yeah, absolutely. Whenever you do anything when you're being observed, it's challenging. Much like the medical emergency practical sessions as well, when you know that you've got a group of people behind a one-way mirror or a two-way mirror watching you. I think it definitely increases the pressure.
Because I feel like in your situation, you had people who had at least some understanding of what was going on. So, like, essentially, not judgment, but
they might know if he was getting it wrong.
Yeah. Whereas for me, the people who were there had no idea what was going on. So if I had done anything like particularly wrong, I don't think anyone would have noticed.
Yeah, and I think it sort of comes back to that team working element that Tamara was talking about earlier, where if you have a group of people who all have different levels of skills and knowledge, but to a certain extent know what to do, you should make it a team effort, and the people with maybe more knowledge shouldn't be scared to speak up and to, if you are doing something that you feel is incorrect, to be able to tell the person.
Definitely. And sometimes it's not even about knowledge, it's about whose human factors might have got the better of them. And we definitely, our dental nurses get exactly the same level of training as our qualified dentists. And although there's differences in their scope of practice, the reason why we think it's so important that everybody has exactly the same level of training is because, your dentist may be the obvious choice, but they're still human behind that. And they can still have a stress response and have a wobble. And as like you said, have every sensible thought just disappear out of their heads. And that's where the team approach, having your dental nurse actually being able to say, I think we should be doing this. It's that supportive approach that will help people manage their human factors. And again, I like that you were you were talking about how everything flooded out, so you started with what you know, the A to E assessment. Slice that elephant. The whole situation in one bite feels way too much, but doing your initial inspection, your audible sounds, chop, 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 and before you know it, you've done a complete assessment, but it feels more manageable because you've used that scaffolding and because you've got that supportive team who can catch you when you have that little bit of a wobble. Whereas for you, nothing. For you, Alicia, you were on your own.
Yeah. I think that's what did make it stressful. So going over, and when everyone is panicking around you, that's when you're like, oh, should I be panicking now at this point? But then I think it was in my head, I had to say to myself, if I panic, then the patient, the person's just probably going to end up worse. And I think it was just a point of where I was like sat on the floor at the side of a road, and I just thought to myself, oh my gosh, like this is a bit crazy. And I think the panic set in when the patient had stopped fitting and they were all saying, oh, he's stopped breathing. And I just thought, if I have to do CPR, I think, yeah.
But you didn't, because you did your A to E and were like, there he's breathing.
He's breathing, he's fine. But yeah, I think I think there's two ways. Like in that respect, it is more stressful, but I do understand in Jonathan's situation, I think I'd feel stress in his position just because of the pressure. Like, I feel like there's that pressure there. And I think also, you know, when it's your patient, like you feel like it's your responsibility a bit more. Like, it's still a responsibility, obviously, if it's someone on the side of the street, but I don't know, it's like if you've been treating a patient and then they go into a medical emergency, you almost feel like you're part of the cause of it, which that's what would scare me.
Well, the patient sees you as the responsible clinician, don't they?
Yeah.
So it's you that's going to get them out of trouble. That would be their expectation. As you would if you went to go and see your GP and had a medical emergency in a GP surgery, you would expect them to have the knowledge and skills to be able to manage it. I would much rather have been in my situation than your situation. Having said that, though.
Yeah, true. Yeah, I think I agree in the sense of that. I think if I'd been in a hospital setting, just having a tutor there, but then at the same time, I feel like this experience has given me confidence for the future. So if I ever was in practice and it did happen, I can think, I did it without the resources, so hopefully I can do it with. And then if you've got a team around you as well, then you, like Jonathan says, you can draw on them, and I won't feel alone as much.
So I think the final thing that I'd like to ask you both is, if you were to pick on one thing that you think really helped you manage this situation, because both of you have managed these complex situations really well. If you were to pull on one of these factors that we've been discussing, what do you think has played the greatest role in your ability to manage this situation? And if you were to be in this situation again, what's the one thing that you might do differently?
So for myself, it's the team working aspect of it, which was really highlighted when we did the practical medical emergencies training. I think we could have worked slightly better as a team. Particularly, and this goes on to the second question of what one thing we would do differently, would be to use that observation sheet and to have somebody scribing all of the time, taking notings of timings and observations. I felt we did okay as a team. I think it's highlighted that there's probably scope for us as a team in these outreach settings to have more regular sort of practicing of it, and maybe just having some drills instead, even if it's just every sort of 6 months, every year, just so we know how to manage it in that particular setting.
Yeah, so practicing the team working aspect in simulation helped, and that would be the thing that you'd want to focus on in terms of your development, because you found that useful.
Yeah, absolutely. I could see how when you get together as a team, particularly in the clinical skills in the skills simulation, where I hadn't ever worked with those people before, you can see how people are different, and you have those human elements to it as well. So that really did highlight how you could come together as a team for the benefit of the patient.
That's great.
Maybe in terms of teamwork, and maybe we should have drills where you have not just students, but students working with tutors on a scenario, rather than just because obviously students work with students on scenarios when you do practice, but maybe students working with tutors, and then that would give experience in how to, maybe it would because I know even though we have the knowledge, I don't know, if I was with a tutor, I don't think I'd contribute as much, just because, I don't know, you just kind of see them as authoritative and you just let them do
Yeah,
what they
so
need
it
to do.
might actually help you
Yeah.
with the team working in
Aspect.
whatever kind of construct of that team is that day.
Yeah.
If you've had the opportunity to learn together.
Yeah.
It's a leveler, isn't it? Learning together is a leveler.
Yeah. Because I just think it'd help in the sense of, like, if you do the simulation but with somebody else who's like maybe not who's like had more experience, for example, then I suppose that's when you'd learn to draw on the different aspects.
Yeah. That's something to take forward at Outreach. That's your project, Jonathan.
Yeah, absolutely. And it is something that we used to definitely do more of in Outreach and on the induction days. I mean, at least you'll have been in a couple, two Outreach settings now. And we've unfortunately had to move a lot of the induction material online. And we used to spend sort of a good hour of each induction day just going through the medical emergencies trolley.
Yeah.
The kit is slightly different over in Hull Outreach as well.
Yeah.
And so I think going forwards, I think we need a little bit more orientation of the students of that kit, because it's likely that they are going to be involved, if not leading, a medical emergency.
Yeah. So, Alicia, what was the thing that you think has been most useful to you, and what else would you do differently, if anything?
So I think the dentane material, for my case, was the most useful, just because it gave me a lot of understanding. And I do remember in fourth year when we started the theory, I did rely more on the quick reference guide.
Yeah.
And I feel like I didn't have that understanding. So I knew what to do, but didn't really know why I was doing it. But then the dentane material was so like well laid out and everything was explained in such a way that you could understand it, that I did the dentane like material and then went back to the reference guide, and it was like, oh, this actually makes sense now.
I know why I'm doing
Yeah,
what
I know why I'm
doing.
doing these things. And I think it's important to know that, just because, like you said, the quick reference guide gives you like standard scenarios, but patients don't always fit into those categories.
Absolutely.
So you have to be able to, like, for example, I did the A2E, but then I kind of went into a doctor's ABC essentially when he'd stopped fitting.
Yeah.
And he wasn't breathing. So it's just kind of being able to adjust your structure.
Yeah.
I think the thing that would change is just the hesitation, because I do feel like I was hesitant, and I do think if it wasn't a life-threatening situation, it would have taken me longer to actually step up and say, oh, I'll help, I think.
Yeah.
Because I think I was hesitant and I didn't feel particularly confident in that sense, and I think it was the fact it was life-threatening that made me think, right, no, you need to do something. But if it wasn't, I think it would have taken me a bit longer to actually like say, oh, no, I can help. I think anyway.
Brilliant. That's great. Well, I believe that Jonathan has prepared a short poem for us on his experience, which seems like a very nice way to finish the podcast.
Okay.
So whenever you're ready,
I'm very
Can't
excited.
wait.
I'm going to take a sip of water. So there's a disclaimer that comes with this particular poem. First of all, so this is from the perspective of a dental student. Definitely not a dental student that's sat in this room today. Maybe a dental student who's slightly less confident with their medical emergency training. Any likeness to any dental students is purely coincidental. I only wrote it this morning. I wrote it in the middle of the night, so it hasn't got a title yet. So I'll just start from the top. I looked at the Crown Prep. It was gorgeous. Could publish in a paper. It was smooth, shiny, no undercut, but with a 60-degree taper. Time for impressions, I declared to the patient, and then you can be off. This one's Frank Spencer. Ooh, Betty, I said, but the patient didn't laugh. I shook the patient's shoulder. Can you hear me? I cried with a high-pitched shrill. The patient stared back at me, dead-eyed and perfectly still. Get the medical emergency trolley, I told my assistant. My fear I could not hide. He finished scrolling through Instagram, rolled his eyes and sighed. My assistant appeared with the trolley. He was pretty quick, to be fair. I often thought he'd be better off selling teas on Ryanair. We tipped the trolley upside down and emptied its contents on the floor. By now the panic was setting in. I wish I'd listened more. I found a pulse oximeter thing. Ah, yes, this needs to be done. I forced the patient's mouth open and attached it to her tongue. I listened for her breathing sounds. Is that a wheeze that I can hear? I pumped and primed a salbutamol and sprayed it in her ear. Maybe they skipped breakfast. I hadn't taken note. I opened a family pack of chocolate hobnobs and shoved them down her throat. I drew up some adrenaline. It can't do any harm, I suppose. I aimed for the outer thigh and missed and hit her nose. I picked up the GTN. I know about this Bayek. I got confused with my other job in boots and sprayed it on her neck. I went looking for the defib pads, but found a disposable razor instead. It must be here for a reason, I panicked and proceeded to shave her head. By now, I was feeling petrified. No joy, no fun, no laughs. I better get my tutor, could still get a commendation on calves. My tutor arrived and surveyed the chaos. He grimaced and took me to one side. I started sobbing uncontrollably. My pain I could not hide. I'm sorry, sir, I tried my best. I think the patient's dead. I think you need to revise medical emergencies, he said. Good job, this was a phantom head.
Wow.
I think that deserves a round of applause. You're actually in the wrong career.
Yes. The 4 a.m. poet. Wow.
I'm actually really impressed.
Me too. Well, that was amazing. And I'd like to thank both of you. So that's Jonathan Pearson and Alicia Hussain for our first Dental Medical Emergencies podcast series. Thank you so much for being with us today. It's been great fun and far more creative than I ever anticipated.
Well, thank you for having us.
Thank you very much.